Hi everyone, my name is Amin Hassan. I am the new sepsis coordinator here at LAMC. Taken on this role since December of last year and new to Kaiser altogether. Clinically, my background is in the ED. I worked at LAC USC Medical Center for several years in the ED and transitioned over to quality improvement, where my focus on was the core measures, specifically sepsis. So thank you so much for having me here today. We'll be discussing um, some of the sepsis related terms, rationale and nursing expectation, what the CMS measure and what I look for in these cases, interventions, and then finally code sepsis, which is a big factor here at LAMC and something that's a emphasis of focus for this year coming up. All right. I like to play this video. It's a really pulls at the heartstrings, but it's very important to see to kind of get your eyes open more for sepsis and what the impact of sepsis is to not only the patient but the family as well.
Here's this perfectly healthy 26-year-old woman who's probably got a head cold. How does she die within 7 hours? Katie died of was a heart attack and major organ failure from the sepsis. She was just married. Her wedding video came about 2 weeks after she died. So she was a rad tech for the last 4 years, and she died at the same hospital she worked at. And the whole time we're thinking it's still the flu, because the flu was going around. And then on New Year's Day, I met her and her husband at the ED. When she arrived, her heart rate was about 160 beats a minute. Her blood pressure was low but stable, vomiting, nauseous, chest heavy. She just kept saying her chest hurted, her chest was heavy. From there, after 9 hours, they couldn't figure out why her heart rate wouldn't go down. I left her at 7:30 that night. She was going to have some more labs drawn and be given some sleep medication. They called us back at 10:45 and said, you need to get back right away. She's taken a turn for the worse. We got there with her husband, and she had coded, but they continued to work on her. They told us we'd never know how she became septic. My son-in-law was a widow at 29. I'm sorry. We had feedback a week ago that someone's husband was taken to the ER with a kidney stone and was admitted, and the wife knew Katie's story and demanded that a doctor test him for sepsis, check his lactate levels, and he was septic. And the wife is convinced, she wrote it on her website, that had she not heard about Katie and knew the symptoms, because we've got them posted everywhere, that her husband could have died. Sepsis kills not only the very young and the very old, or those with the compromised immune system or central line, but we want people to think of Katie first when they come across the symptoms of sepsis so that they can question themselves. It's been difficult for our whole family. It's been difficult for my son-in-law. It's incomprehensible, the depth of pain as a parent. And if we can help anybody, that's really what we want to do.
And so, a very, very heartfelt video, and it's sad to see that. But number one cause of death in U.S. hospitals is related to sepsis. 1 in 3 patients who dies in a hospital has sepsis. Its impact across the nation is really, really difficult to see and understand, and it is also the number one cause of readmissions. Even for us here at LAMC, one of our highest causes of readmission are sepsis patients. Patients who had sepsis were discharged and made it back within 30 days um, because they're still feeling it. And so there's a big, big emphasis on sepsis. CMS uh, collects data from all the hospitals, and this is a publicly reported data for each hospital that treats sepsis and what our numbers are. And that's really what I do is I focus on that. And so who's at risk for sepsis is the usual characters, right? They're very old and they're very young, but we focus on the adult population here, or at least for what I'm doing. And people that have chronic medical conditions, diabetes, lung cancer, lung disease, cancer, people who've had sepsis in the past are more a high risk for getting sepsis again, weakened immune system, or any severe illnesses, right? Google has this cool tool that you can do where it can trend terms. And so I put in sepsis, stroke, and heart attack. And what you're seeing here is the amount of people that have typed in or searched for stroke, heart attack, and you can see sepsis is at the very bottom. Although it's the number one cause of death in hospitals, it is still at the very bottom because it's just not well known. It's not something that people really, really quite understand. And that's what we're trying to do here. So what is sepsis? Sepsis is the body's extreme response to the infection. So it's not the infection in itself, but it's the way the body responds to it. And it is a life-threatening medical emergency. Sepsis Alliance, sepsis.org, really push a lot of information out to the community. They talk about time because timing is everything with sepsis. Labs have to be drawn at a certain time, antibiotic needs to be given by a certain time, fluids need to be given. And so everything is revolved around time. And the immune system triggers a chain reaction through the body, which causes sepsis, and it continues on through a continuum, right? And so what we want to try to do is recognize it and act immediately when we see our patient developing sepsis. And sepsis has long-term impact, right? You're talking about permanent organ damage with amputations or kidney failure. Your risk for infection is higher. 60% of people experience worsened cognitive function. Studies are now showing post-sepsis syndrome, where half of survivors are having insomnia, nightmares, panic attack, extreme fatigue, joint pain, muscle pain. And so there's a big emphasis on identifying sepsis and treating it properly, right? This video I like to play because it's a really good patho visit video explaining what the body goes through when the infection invades the body and the body's response in developing sepsis. So let's watch this video real quick.
As critically ill patients fight infectious insults, there is often an excessive response that results in the syndrome of severe sepsis. Clinically, you may see increases in temperature, heart rate, respiratory rate, and abnormalities of white blood cell count or differential. As the disease progresses, blood pressure may drop with organ hypoperfusion, and organ systems such as the respiratory, cardiovascular, hepatic, central nervous, and renal system may fail. Traditionally, this excessive response has been associated with the disruption of homeostasis through an uncontrolled cascade of inflammation, coagulation, and impaired fibrinolysis. Deeper examination shows that the microcirculation is the key focus of sepsis injury. The sepsis cascade begins with the activation of the capillary endothelium in response to an infectious agent or toxin. This endothelial damage exacerbates the inflammatory process, resulting in neutrophil activation and expression of adhesion molecules. Neutrophils begin to roll in the capillary and adhere to the endothelium. The increased endothelial permeability leads to a loss of vascular integrity and consequent microvascular leakage. In the lungs, this interstitial and alveolar edema leads to acute lung injury and acute respiratory distress syndrome. Concomitantly, coagulopathy and impaired fibrinolysis prevent red blood cells from delivering oxygen to the organs, resulting in inadequate perfusion and global tissue hypoxia. The amplification of the coagulation pathway results in large amounts of thrombin formation, which converts fibrinogen to fibrin. Fibrin threads with activated platelets form a clump at the site of endothelial activation. Reduced arterial vascular tone, diminished venous return, and the release of myocardial depressant factors lead to hypotension. This is a scan of the capillary circulation in a normal patient. Note the rapid blood flow and numerous capillary loops. Now you see a patient in septic shock despite restoration of normal hemodynamic parameters through treatment with fluids and vasopressors. Note the poor blood flow and capillary loops with intermittent or occluded flow. The depressed myocardial function, widespread tissue ischemia, and multiple organ dysfunction often lead to patient death.
It's a really good video and explains the pathophysiology of sepsis, right? So you get that initial inflammation or anti-inflammatory processes kind of triggering it, right? Then we get our reactions in the humoral and cellular levels, causing the circulatory abnormalities. And then, of course, you get the vasodilation that causes the hypotension. And that's when the fluids are really important. And we'll get to that in just a bit of administering IV fluids to patients that are have hypotension. Changes in the endothelial changes with our acute organ dysfunctions, right? Resulting in the capillary leaks. And so what does sepsis mean as far as what I do? I review either concurrently or retrospectively all cases of sepsis in the hospital. And what I look for is I base my reviews on the CMS guidelines and determining whether or not this patient is meeting our severe sepsis or septic shock criteria. And the process is the same for either sepsis, severe sepsis, or septic shock, meaning labs need to be drawn, antibiotics need to be given, a repeat lactate needs to be drawn if the initial one was high, fluids need to be given if hypotension is there, vasopressors need to be started if they're not responding to the fluids given. And so the process remains the same. And this is what we really want to stress about, is trying to identify that early recognition. The earlier we can recognize this in a patient, the sooner we can get treatment going. And if we look at the first box up here, that's our SIRS criteria, right? And SIRS criteria can be triggered not only from an infection, but from trauma, inflammation, and even surgery can kind of trigger a SIRS criteria. And what SIRS criteria has 4 different elements that we look for, right? A temperature that's less than 36 degrees or greater than 38.3 degrees Celsius, respiratory rate that's greater than 20, a heart rate that's greater than 90, and WBC is either greater than 12 or less than 4, or if there's a greater than 10% band, a shift to the left, right? Q-SOFA is typically used by physicians, and you'll see that sometimes in the ICU unit will have a Q-SOFA or a SOFA criteria being documented, but what we focus on is on the SIRS, and that's what we want to point at. And so for sepsis, if you have 2 out of the 4 SIRS criteria met, next thing you want to look for is to know whether or not there's a known or suspected infection. And so if you have a known or suspected infection and you have 2 or more SIRS criteria being met, the next thing you want to see is there any acute organ dysfunction? And that can be any one of these being triggered, and that's either systolic blood pressure less than 90 or a MAP less than 65, creatinine that's greater than 2 for a non-dialysis patient, bilirubin greater than 2, altered mental status, platelet that's less than 100, INR or PTT elevation in those, or lactic acid. A lot of times you'll see that lactic acid being greater than 2 as the trigger, or a patient that either requires a BiPAP or needs to be intubated. So any one of these will place our patient in the category of severe sepsis. In order to be in septic shock, outside of a physician documentation, but clinically, is having your initial lactate greater than or equal to 4, or a patient that has a persistent or sustained hypotension, which will be a systolic blood pressure less than 90, or a MAP that's less than 65 after fluids have been given. You'll see this 30 mLs per kg a lot when it comes to IV fluids, but ultimately the physician has an opportunity to give less if there are other comorbidities impacting that decision of giving 30 mLs per kg. And we'll discuss that in the later slides as well. And so what we're asking, and what the best practice has been in the medical centers in our region, is that in that first hour, once we have identified a known or suspected infection and that patient has two or more SIRS criteria, we're asking that the labs be drawn within that first hour. And we're talking about CBC, a lactic acid with reflex to repeat. So it will automatically trigger the repeat lactate to be drawn if the initial one is greater than 2. We're asking blood cultures to be drawn as well within that first hour. And ideally, if we can, to give the antibiotics within that first hour as well. Now, if for some reason we can't give that antibiotic within the first hour, as soon as practical, we want to, and it needs to be given within the first 3 hours of time 0. And time 0 is really just the time that sepsis has been identified, right? And so we want to try to get the antibiotics within that time frame. If within those 3 hours the patient is developing hypotension, we want to make sure we give the 30 mLs per kg on the fluids of either NS or LR. Again, and a physician can give less than the 30 mLs per kg. It just requires their documentation, and that's something that I can do with the physicians when I'm reviewing these cases. For obese patients, a physician can choose to use the ideal body weight and base the 30 mLs per kg on that as well. And that's another option that they have. If that initial lactate comes back greater than 2, we want to make sure the repeat lactate is there. And that's why having the order of lactic acid with reflex or repeat allows us to get that repeat lactate in time. And then the assessment of response to the fluid really falls on the physician, but we need to make sure that they're doing the reassessment if this patient has persistent or sustained hypotension, and after giving fluids and they remain in that hypotensive state. And so that it's upon the physician to do a reassessment for them. And again, that's something I can do via reviewing the charts and reaching out to the physician itself. This is a case study. We try to base this case study off of an actual patient that came through here. So you have a 67-year-old female admitted for CHF exacerbation. She's day 1. She's on the unit, inpatient now, coming from a skilled nursing facility. History of heart failure, hypertension, AFib, dementia, and arthritis. Current assessment showing that she's oriented to name only, slightly restless, can follow simple commands. She has diminished breath sounds and crackles in the lower lobes, and she's incontinent with no urine output noted at this time, so her PureWick is in place. Just looking at the vital signs here, she got a heart rate of 110. Respirations of 26 are elevated, and her temperature is greater than 38.3. So, ideally looking at this, you would see that she's triggered her SIRS criteria, and she's triggering sepsis, right, with a known or suspected infection, possibly UTI, possibly pneumonia with the crackles that are heard in the lungs. So it should automatically start getting you to start thinking, okay, is this patient starting to get sick? They have a temperature now. What are some of the things that I need to do? And so with this patient, you're putting them on a nasal cannula, 4 liters. An EKG shows the AFib, which is a known history. Still no urine output, and so you get the order for a Foley to be inserted, and we see 20 mLs of dark amber urine being in there. Another set of vital signs are showing now she's getting a little hypotensive, right? She went systolic, she was in the hundreds, and now she's in the 85. Her heart rate's starting to get up, and she's starting to get more tachypnic as well. Temperature's still greater than 38.3, right? And she's needing more oxygen in because we're putting out 4 liters. And so you get orders. You get your orders for your IV fluids, your stat lactate, your blood cultures. You call X-ray, you draw the labs up as well. Ceftriaxone is ordered, and we're ordering acetaminophen for the fever, and the Foley catheter has been in place, right? And then again, so fluids are calculated 30 mLs per kg. If we were to give this to this patient based off of the physician order of 30 mLs per kg, we're looking to give about 1380 mLs to meet the patient's need for IV fluids, right? And so as a nurse, what are your roles? It's immediately notify your physician, right? You want to set your vital signs Q15 because we want to make sure we capture any hypotension that the patient may be in. You notify patient outcomes or call an RRT via Versera. Patient outcomes is aware of the protocols for sepsis, and they have it within their protocols to order labs, lactate, blood cultures. They can give 500 mLs of NS if the patient is hypotensive. And they can also order an additional 500 mLs if the patient remains in hypotension after the first fluids were given. And so they can give up to a liter just by them showing up. And we encourage our nurses to utilize patient outcomes. As they will come, they will bring down their NICOM, and they'll be able to assist and provide support, reach out to physicians to get the process rolling for this patient, right? And so the 3 interventions that require ASAP are, of course, are the lactate with reflex to repeat, your blood cultures, and given the antibiotics. Remember, those are the 3 things that we want to try to get done within the first hour. And so we're talking about lactate, blood cultures, of course, before giving the antibiotics, and then administering fluids if this patient is hypotensive. And if the patient remains hypotensive after giving fluids, we want to check that by doing at least, at minimum, 2 blood pressure checks within the first hour of the fluid bolus completion. And that's extremely, extremely important. One of the things we see a lot of misses on are either the completion time of the IV fluids given or no blood pressure is documented after the IV fluids are given. And the thing is with the sepsis measure, if there is a missing completion time or if there is a missing blood pressure reading, that takes our case out of the measure. What does that mean? That means it's a failed case, right? And so we want to make sure that we complete everything within our capabilities, and that's drawing the labs, drawing the blood cultures, giving antibiotics, administering fluids when we need to, and making sure we're documenting completion time of the fluids and at least 2 blood pressure readings within that first hour of IV fluid completion. And that's why it's important to set your monitor to Q15, right? And this way it'll capture it for you. And the same thing goes for septic shock, as I mentioned earlier, right? This patient can go from SIRS to septic shock. They're not necessarily going to go SIRS, sepsis, severe sepsis, septic shock. They can go straight to septic shock. And it's, again, our duty to identify that and recognize that this patient is declining, and we want to notify patient outcomes or call an RRT so they can get to the bedside, give them oxygen, draw our labs, draw our blood cultures, administer antibiotics. If this patient is hypotensive, make sure we're giving those fluids and documenting completion time, as well as documenting 2 blood pressures within that hour of IV fluid bolus completion. And if the patient remains in that hypotension, again, it's talking about giving IV fluids, 30 mLs per kg, rechecking that blood pressure. Who we're going to call? We're going to call our rapid response team or patient outcomes, and that they'll help determine if there needs to be vasopressor given, especially if the patient remains in hypotension. And to get that repeat lactate if the initial lactate is greater than 2. And we go back to our patient here in our case study. You know, the UA was sent, labs were drawn, blood cultures were drawn, IV fluids were given, right? We gave the acetaminophen, ceftriaxone is ordered. The patient is currently denies difficulty breathing, but the bilateral lower lobe still has those crackles. Taking a look at the Vital signs, she's still soft systolically at 92. Heart rate has come down a little bit. Her breathing has improved slightly. She's still showing a little bit of a temp. If we look at the labs, you can see her white count is elevated. She has a elevated lactic acid, right? And and it looks like her UA is coming back with a possible UTI. We talked about the fluids. So this is called CHEETAH or NICOM. It's an invasive device that's used to determine a patient's fluid responsiveness, right? And so we don't want to continue to flood patients with fluids on fluids, especially a patient who has CHF or a history of CHF as well. And so this kind of determines whether or not the patient is responding to fluids. Patient outcomes will come down, they'll set it up, and it's a tool that we encourage more physicians and nurses to use to help them determine the patient's responsiveness to fluids. Now, if there's a change in stroke volume that's equal to or greater than 10%, then that patient is fluid responsive, excuse me, and can get additional fluids given. And so it can help the physician determine whether or not to give additional fluids. And it's typically given with a 500 ml challenge. And we just want to make sure that when this is being used and utilized, that the order is actually put in for the 500 ml. Sometimes the verbal order is given and we do it. However, it's not representative in the MAR, and it's really important to make sure that we get that documentation. So after all of our interventions of fluids, labs, antibiotics, acetaminophen, we have our 2 blood pressure readings showing that the patient improved in the systolic blood pressures. Heart rate is continuing to come down. She's still a little tachypnic, but her temperature's come down, and now she's on 2 liters of nasal cannula with a oxygen saturation of 98%. So this patient was stabilized, did not need to be transferred to ICU, did not receive vasopressors. Patient condition improved. They remained on the med-surg tele unit and was eventually discharged back to the SNF. And this is a typical or an ideal situation that we want to see, right? We early recognition of sepsis. We did the interventions that we needed to do, which was draw labs, draw blood cultures, give antibiotics. The patient became hypotensive, and we gave fluids when it was necessary. We utilized the NICOM, which determined that the patient had fluid responsiveness, and this is the final outcome, right? Patient has been stabilized and no longer needed to be transferred to ICU, and eventually went back to their SNF. One of the ways that you can use to document your completion time is via the mini-MAR. And speaking to our informatics department, I guess this went live in December of 2021 for inpatient, and it allows you to document the completion time of the IV fluids given, and it allows you also to document the blood pressure. And so if you utilize this mini-MAR in the flow sheet, it'll help, it'll document what's necessary in the MAR for a completion time. And then it also will show up in the flow sheet with the blood pressure reading that was input into this mini-MAR. And then you'll see it at the bottom. Will show me time that the fluids were given and the time that it was completed. Because sepsis is the number one cause of readmission in hospitals, it is really important for us to provide the education that they need. This is the patient education workflow of what we need to do. So if a patient is either being admitted for sepsis or develops sepsis while an inpatient, we are responsible to make sure that we provide sepsis education for them. And that's using the sepsis education video as well as this life after sepsis handout on discharge as well. And this is the job aid for the video that the patient can view for sepsis education. And then this would be the life after sepsis discharge paperwork that we want to make sure that they get. Code sepsis is a big move that we're trying to push for 2022. I know with the pandemic that a lot of code sepsis calls were not being made because of the current situation, but whenever a code sepsis is called, which can be initiated by either myself as a sepsis coordinator, patient outcomes, or the physician themselves can call code sepsis. What that does is it brings more resources to the bedside, and it will bring lab over there as well, so they can start initiating and drawing the labs. Pharmacy is aware of the code sepsis, and they'll make a priority to make sure that we get the antibiotics within that patient to that patient within the hour of a code sepsis being called. So it's really important to do that, and that's why we encourage or are encouraging nurses to call patient outcomes, utilize that resource, have them get to the bedside, let them give an assessment, and if code sepsis is deemed necessary, they can go ahead and initiate that code sepsis. And that's exactly what we're talking, right? So if a patient has SIRS and initiates a sepsis alert, right? They have SIRS and a known or suspected infection. And patient outcomes can come assist and see that this patient now has an acute or organ dysfunction. They can go ahead and initiate that code sepsis, which will then initiate that 1 hour bundle. That 1 hour bundle again is our labs, which will be CBC, BMP, lactic acid with reflex to repeat, our blood cultures. We want to give them fluids, and we also want to get the antibiotic started as well. If this patient is starting to develop are not stable and still remain in hypotension, then vasopressors can be considered. And then at that point, we'll be ready to move and transfer that patient to a higher level of care. Patient outcomes at the bedside will also be able to call bed control and determine where this patient can go if they need to be transferred out of your unit. These are buddy badges. Please make sure you have one. It's a great tool to have. It gives you all the things that you need necessary for sepsis. It kind of gives you the SIRS criteria. It shows you what is considered organ dysfunction. So it's a really good reminder of what you need. And on the backside, it tells you what the treatment is, right? Lactate level, blood cultures, antibiotics, fluids if necessary. And also it gives you a criteria for septic shock and what is needed and what is necessary. And it kind of gives you that time frame of what needs to be done within 3 hours, what needs to be done within the 6 hours. So really, really good tool. Please make sure you grab one and have it on your badge. This is a KP Learn developed by our region, and I would like for everyone to be able to take this module and it'll, based on our region and some of the medical practices in our region, best practices are showing that the more staff that completes the KP learning module, the more compliance we have with our sepsis. And so we're encouraging you to please go to your KP Learn and complete the sepsis module. This is my contact information. I am located in the ED in Pod B. You can text or call me. You can send me an email. I also have a desk line that you can reach out to, and I'm also on Vocero. So please, if there's any concerns, any questions regarding your patient or a patient you may have had, please feel free to reach out to me. I'll be more than happy to discuss any information that I can provide for you. And that's it. Thanks again, everybody.
Yay, thank you so much.
All right, I hope that was good.
Yeah, it will generate in a little bit, and then if you wanted to watch it, you can also watch it if you want.
Okay. Yeah, I mean, if there's any questions that they may have, I want to try to be available. So if you're getting questions, after showing this, and I'm not sure what the best way to go about it, but please, feel free to reach out to me, and I can try my best to answer questions.
Okay, for sure. So our telemetry, so Jasper has like the North Tower, which is 2 north, 4 north, and 7 east. And then Perla and Hetty, we have 6 west, 7 west, and then 5 west. So we're actually having like 2 sessions a day. So I can I'll send you an email of the dates that we have if you have time to stop by, you can. And then we'll probably like be doing some other other stuff too, but if you just wanted to swing by, we can do that too.
Absolutely. Yeah, for sure. What I can do is I think next week is the one for the North Tower.
Yes.
And then what I'll do is I'll just bring a bunch of these badge buddies. I have quite a few, and maybe drop them off, and then this way we can make sure that staff is getting these badge weddings.
All right. Did you want us to, you want to bring it or do you want us to pick it up now or?
No, I can drop it off when I go. That's not a problem.
Okay, sounds good.
Yeah. Awesome.
Once again.
All right. Yeah. Thank you so much.
I'll send you another invite too. We have new grads coming in June. So
Okay.
it'd be like that same talk like after like a simulation. I apologize. Hopefully this time we'll really
Yeah, of course, no problem. Absolutely. Please. Yes. If there's another one, I'll be more than happy to kind of come down and present. That'd be awesome.
all right. Thank you.
Thank you. Have a great day.
You too. Bye-bye.
Bye bye.